Bloodstream infections, BSIS, are a significant complication in dialysis patients. What are the key infection control strategies that should be implemented in the dialysis unit to reduce the risk of BSIS, and how do they align with CDC guidelines? Answer. Bloodstream infections in dialysis patients are typically caused by bacterial or fungal pathogens introduced through dialysis access sites. Infection control strategies must focus on minimizing exposure to pathogens and preventing access site contamination. The CDC's dialysis infection prevention guidelines outline several measures. Hand hygiene. Proper hand washing with soap and water or alcohol-based hand sanitizers is critical before and after patient contact, particularly before vascular access manipulation. Aseptic technique. Strict aseptic techniques should be adhered to during the insertion of needles or catheter access to prevent pathogen introduction. Environmental cleaning and disinfection. Dialysis stations and equipment must be disinfected regularly using hospital-grade disinfectants to prevent the growth of bacteria like Staphylococcus aureus and other pathogens. Surveillance. Regular monitoring and reporting of infection rates help to identify trends and implement corrective actions. A pediatric patient with chronic kidney disease (CKD) is showing delayed growth. How does CKD affect growth hormone activity in children, and what interventions should be considered to address these concerns? Answer. CKD in children can affect growth by disrupting the normal secretion of growth hormone, GH. This disruption may occur due to malnutrition. Reduced kidney function impairs the ability to process nutrients, leading to malnutrition, which directly impacts growth hormone activity. Uremic toxins. Accumulation of uremic toxins can interfere with growth hormone receptors and disrupt the growth plate function. Vitamin D deficiency. Chronic kidney disease often leads to deficiencies in vitamin D, further impairing bone growth and development. Interventions. Growth hormone therapy. In some cases, recombinant human growth hormone or AOH therapy may be recommended to stimulate growth. Nutritional support. A high-calorie, high-protein diet with adequate vitamins and minerals can support normal growth in pediatric CKD patients. Vitamin D supplementation. Ensuring adequate levels of active vitamin D is essential to maintain normal bone growth and mineral metabolism. In the context of dialysis units, why is environmental cleaning and disinfection essential, and what are the best practices recommended by the CDC to reduce infection transmission? Answer. Environmental cleaning and disinfection in dialysis units are critical to prevent the transmission of infectious agents that can cause hospital-acquired infections, highs such as bloodstream infections, BSIS, and peritonitis in peritoneal dialysis (PD) patients. The CDC recommends the following best practices. Routine cleaning. All surfaces, including chairs, tables, and dialysis machines, should be cleaned after every patient use using EPA-registered disinfectants. High-touch surfaces. High-touch surfaces such as door handles, bed rails, and computer stations should be disinfected frequently throughout the day. Dedicated equipment. If possible, assign dialysis machines and equipment to specific patients to reduce cross-contamination risks. Floor and air quality. Floors and ventilation systems should be cleaned regularly to reduce the presence of airborne pathogens. CDC guidelines. According to the CDC's environmental cleaning guidelines for dialysis centers, cleaning schedules and protocols should be followed rigorously to maintain a sterile environment. Mr. Anderson is a 5-year-old child with end-stage renal disease (ESUD) requiring hemodialysis. His parents are concerned about the impact of dialysis on his growth and development. What strategies should Mr. Anderson's nephrology nurse consider to address these concerns, and how can the nurse educate the family on the potential outcomes? Answer. Mr. Anderson's condition requires careful management to address growth and development concerns related to ESRD. Key strategies include growth hormone therapy. If Mr. Anderson's growth is significantly delayed, the nephrology nurse may consult with the pediatric endocrinologist about the potential use of recombinant growth hormone to promote growth. Nutritional support. The nurse should work with a dietitian to ensure that Mr. Anderson receives a diet that supports growth, including adequate protein, calories, and vitamins, especially vitamin D. Psychosocial support. Ensuring that Mr. Anderson and his family have access to support groups can help manage the emotional and psychological impact of living with ESRD and undergoing dialysis. The nurse should also educate the parents about potential long-term outcomes such as improved growth with early intervention, the importance of routine monitoring, and potential adjustments to dialysis regimens. What are the common types of infections seen in peritoneal dialysis (PD) patients, and what infection control measures are most effective in preventing these complications? Answer. The most common infections in PD patients are peritonitis. This is an infection of the peritoneal cavity and is typically caused by bacteria entering through the catheter during dialysis exchanges. Exit site infections. These occur at the catheter insertion site and can progress to peritonitis if untreated. Infection control measures. Sterile technique. PD patients must follow strict aseptic techniques during each exchange to prevent contamination. Catheter care. The catheter insertion site should be cleaned daily with an antiseptic solution, and patients should be educated on signs of infection such as redness or tenderness at the site. Antibiotic prophylaxis. Some units may recommend prophylactic antibiotics for patients with a history of peritonitis or high infection risk. What are the specific nutritional considerations for pediatric nephrology patients, particularly those with chronic kidney disease, CKD, and how do these differ from the nutritional needs of healthy children? Answer: pediatric patients with CKD require careful management of their nutritional intake due to altered metabolism and the effects of kidney dysfunction on nutrient processing. Key considerations include protein restriction. To reduce the burden on the kidneys, children with CKD may require controlled protein intake. This must be balanced to ensure that growth and development are not compromised. Calcium and phosphorus balance. CKD can lead to imbalances in calcium and phosphorus levels. Supplementation or dietary adjustments may be necessary to prevent bone disease. Sodium and fluid restriction. Due to impaired kidney function, excess sodium and fluid can accumulate in the body, leading to hypertension and edema. Vitamin D. Supplementation with active forms of vitamin D is often needed to manage mineral bone disorder. Difference from healthy children. Unlike healthy children, CKD patients must avoid excessive potassium, sodium, and phosphorus while ensuring adequate caloric intake for growth. The diet should be tailored to their kidney function stage. Why are hand hygiene protocols critical in preventing infections in dialysis units, and what specific guidelines does the CDC provide for healthcare workers in these settings? Answer: hand hygiene is considered the single most important method for preventing the transmission of infections in healthcare settings, including dialysis units. The CDC recommends the following hand hygiene protocols. Hand washing with soap and water should be done when hands are visibly soiled or after caring for patients with infectious conditions. Alcohol-based hand sanitizers should be used when hands are not visibly soiled, especially before and after patient contact and before and after vascular access manipulation. Glove use. Gloves should be worn during procedures that involve direct patient contact or handling of dialysis equipment, but proper hand hygiene should still be performed before and after wearing gloves. CDC's hand hygiene guidelines for healthcare settings emphasize both education and auditing to ensure adherence to these protocols. A newborn has been diagnosed with polycystic kidney disease (PKD). What are the expected clinical manifestations of PKD in a neonate, and what interventions should be implemented for early management? Answer: neonatal polycystic kidney disease (PKD) can manifest with the following clinical signs: abdominal distension due to enlarged kidneys, which can be detected on prenatal ultrasounds or during physical examination; respiratory distress. Compression of the lungs by large kidneys can impair normal lung expansion, leading to breathing difficulties; hepatic dysfunction. In some cases, hepatic cysts may also be present, causing liver enlargement and potential jaundice. Interventions. Supportive care. Immediate management includes respiratory support if needed and monitoring renal function closely. Family counseling. Genetic counseling is essential, as PKD is often inherited. Families should be informed about the prognosis and potential need for renal replacement therapy in the future. The CDC has specific infection control guidelines for dialysis centers. What are the key elements of these guidelines that nephrology nurses must follow to ensure patient safety? Answer: the key elements of the CDC's guidelines for dialysis centers include staff training, regular training on infection control procedures, including aseptic techniques, proper hand hygiene and catheter care, routine infection surveillance. Dialysis centers should regularly monitor infection rates and conduct audits to identify potential sources of infection. Environmental cleaning, regular disinfection of patient care areas and dialysis machines according to CDC recommended practices. Vaccination. Hepatitis B vaccination for all dialysis patients and staff to prevent blood-borne infections. What are the unique challenges associated with pediatric dialysis protocols, and how should nephrology nurses adjust standard adult dialysis regimens to meet the needs of pediatric patients? Answer: pediatric dialysis protocols must account for the unique anatomical and physiological differences between children and adults. Key challenges include smaller body size. Pediatric patients require dialysis machines and dialyzers that are appropriately sized for their smaller body mass. Fluid removal rates and dialysate volumes need to be adjusted accordingly. Growth considerations. Dialysis regimens must be modified to prevent excessive fluid removal that could impair growth or cause electrolyte imbalances. Psychosocial impact. Pediatric patients and their families require additional psychological support to cope with the emotional strain of long-term dialysis. Adjustments to adult protocols. Dialysis duration. Pediatric patients may require longer dialysis sessions due to the smaller size of their kidneys. Fluid management. The nurse must carefully monitor fluid status to avoid dehydration, which can adversely affect growth. What is the role of aldosterone in regulating fluid balance, and how does it interact with the actions of antidiuretic hormone ADE? Answer: aldosterone and ADH are both crucial in regulating fluid and electrolyte balance, though they operate through different mechanisms. Aldosterone, a steroid hormone secreted by the adrenal cortex, primarily acts on the kidneys, distal convoluted tubules and collecting ducts. It promotes sodium reabsorption and potassium excretion. This sodium retention leads to water retention, thus increasing blood volume and blood pressure. ADH, also known as vasopressin, is secreted by the posterior pituitary in response to increased plasma osmolality or low blood volume. ADH acts on the collecting ducts, increasing their permeability to water by stimulating the insertion of aquaporin channels. This allows more water to be reabsorbed back into the bloodstream, further concentrating urine and increasing blood volume. Together, aldosterone and ADH help maintain fluid balance and homeostasis, though their mechanisms are distinct. Aldosterone influences sodium and water retention, while ADH directly regulates water retention based on plasma osmolality. They often work in tandem in conditions like dehydration or volume depletion, where both mechanisms act to restore fluid balance. What are the primary causes and clinical implications of hyperkalemia in patients with chronic kidney disease C? Answer: hyperkalemia is a common electrolyte disturbance in patients with CKD due to the kidney's decreased ability to excrete potassium. Normally, the kidneys play a major role in maintaining potassium homeostasis by filtering and excreting potassium through the urine. However, in CKD, impaired kidney function reduces this ability, leading to potassium retention. The causes of hyperkalemia in CKD can be multifactorial, including decreased renal excretion due to impaired glomerular filtration rate (GFR), acidosis, which can shift potassium from the intracellular to the extracellular space, medications such as ACE inhibitors, angiotensin receptor blockers, ARBs, potassium-sparing diuretics, and certain non-steroidal anti-inflammatory drugs, NSAIDs, which can further reduce potassium excretion. Dietary intake of potassium-rich foods or supplements may exacerbate the condition, especially in advanced CKD. Clinically, hyperkalemia can lead to life-threatening arrhythmias, including ventricular fibrillation or a systole, making prompt recognition and treatment essential. Treatment involves reducing potassium intake and modifying medications that contribute to potassium retention, potassium binders, e.g., sodium polystyrene sulfonate, to lower serum potassium levels. Dialysis in severe cases where renal function is insufficient to manage potassium balance. How is metabolic acidosis in CKD compensated by the body, and what are the clinical implications of this compensation? Answer: metabolic acidosis is a common complication of CKD arising when the kidneys are unable to excrete hydrogen ions H effectively or reabsorb bicarbonate HEO. This leads to an accumulation of acid in the bloodstream, lowering the pH. Compensation mechanisms for metabolic acidosis include respiratory compensation. The body compensates by increasing ventilation, hyperventilation, to expel more carbon dioxide, which helps decrease the concentration of carbonic acid (HCl) in the blood. This mechanism is fast-acting and occurs within minutes to hours. Renal compensation in the long term. The kidneys attempt to compensate by increasing the excretion of H and reabsorbing bicarbonate. However, in CKD, this compensatory response is often impaired due to reduced kidney function, and metabolic acidosis can worsen over time. The clinical implications of metabolic acidosis in CKD are significant. It may lead to bone demineralization, as the body buffers the acid by releasing calcium from bones, worsen cardiovascular risk due to increased vascular calcification and endothelial dysfunction, impaired drug metabolism due to altered pH and electrolyte imbalances. Treatment often involves bicarbonate supplementation to correct the acidosis and prevent complications. In some cases, dialysis may be required if the acidosis is severe and cannot be corrected with medical management alone. Mr. Roberts, a 58-year-old man with stage 4 CKD, presents to your clinic with complaints of muscle weakness and palpitations. His latest lab results show a potassium level of 6.2 meckel. He has been taking an AC inhibitor for his hypertension. What should Mr. Roberts' healthcare team do next, and why? Answer: Mr. Roberts is presenting with symptoms consistent with hypokalemia, muscle weakness, and palpitations, and his potassium level of 6.2 meckel is above the normal range, 3.55.0 meckel. This elevated potassium level is likely exacerbated by his AC inhibitor, which inhibits aldosterone, impairing potassium excretion by the kidneys. The healthcare team should immediately discontinue the AC inhibitor, as this medication could contribute to hypokalemia by reducing potassium excretion. Assess the severity of hypokalemia and its associated risks, e.g. CG changes. If CG abnormalities, e.g. peaked T waves, widening of QRS complex are present, urgent treatment may be required, such as administering calcium gluconate to stabilize the myocardial cell membrane, administering sodium bicarbonate, insulin, and glucose to shift potassium back into the cells. If necessary, initiate dialysis to remove potassium from the bloodstream. Reassess Mr. Roberts' overall fluid and electrolyte balance and consider starting potassium binders or adjusting his diet to lower potassium intake. What are the indications for the use of erythropoiesis-stimulating agents (ESAs) in CKD patients, and what are the potential risks of their use? Answer: Erythropoiesis-stimulating agents (ESAs) are used in CKD to treat anemia, which is common in patients with impaired renal function due to reduced erythropoietin production by the kidneys. ESAs such as epoetin alpha and darbepoetin alpha stimulate the bone marrow to produce more red blood cells, thereby improving hemoglobin levels. The indications for ESA use in CKD include hemoglobin levels 10 grams, though the target may vary based on individual patient conditions, symptomatic anemia, fatigue, shortness of breath, dizziness impacting the patient's quality of life, inadequate response to iron supplementation when ferritin levels are sufficient, but anemia persists. However, the use of ESAs carries risks, such as increased risk of cardiovascular events, including stroke, heart failure, and myocardial infarction, especially when hemoglobin levels are raised too quickly or above recommended thresholds. Increased risk of thrombosis, as higher hemoglobin concentrations can lead to blood clot formation. Hypertension, as the ESA therapy can raise blood pressure, requiring close monitoring. Therefore, ESAs should be used cautiously with regular monitoring of hemoglobin levels, iron status, and cardiovascular health to minimize these risks. What are the clinical differences between hyponatremia and hyponatremia, and what treatment approaches are typically recommended for each condition in CKD patients? Answer: Hyponatremia and hyponatremia are both sodium imbalances, but they represent opposite extremes and have distinct clinical features and treatment approaches. Hyponatremia occurs when serum sodium levels exceed 145 meckel, often due to water loss, dehydration, or inadequate water intake. In CKD, patients may be at risk due to impaired renal water excretion. Symptoms of hyponatremia include: first, confusion, irritability, and in severe cases, seizures or coma. Treatment involves careful fluid rehydration, often with hypotonic fluids IDW 0.45% saline. Correction should be slow to avoid cerebral edema. Hyponatremia, on the other hand, occurs when serum sodium levels fall below 135 meckel, and it is often due to excessive water retention or sodium loss. In CKD, hyponatremia may arise due to fluid overload, diuretic use, or syndrome of inappropriate antidiuretic hormone secretion. Symptoms include nausea, headache, confusion, and in severe cases, seizures or coma. Treatment typically involves fluid restriction and careful sodium replacement with hypotonic saline 3% NaCl in severe cases, with monitoring of sodium levels to avoid overly rapid correction. What is the mechanism of action of phosphate binders in CKD, and why are they crucial in managing hyperphosphatemia? Answer: phosphate binders are used to treat hyperphosphatemia in CKD, a common complication due to impaired renal clearance of phosphate. These binders work by binding to dietary phosphate in the gastrointestinal tract, forming insoluble complexes that are excreted in the stool, thus preventing phosphate absorption. The main types of phosphate binders include calcium-based binders, e.g. calcium acetate, which not only bind phosphate but also provide calcium, potentially correcting hypocalcemia. Non-calcium-based binders, e.g. sevelamer and lanthanum carbonate, which do not add calcium but are preferred in patients at risk for vascular calcification or those with already elevated calcium levels. These binders are crucial in managing hyperphosphatemia because high phosphate levels can lead to vascular calcification, worsening cardiovascular outcomes and contributing to bone mineralization disorders. Explain how renal dosing adjustments are made for medications in CKD patients and give examples of medications that require careful adjustment. Answer: renal dosing adjustments are necessary for drugs that are excreted by the kidneys, as decreased renal function can lead to drug accumulation and toxicity. In CKD patients, the dose or dosing interval of such medications must be adjusted based on the patient's estimated glomerular filtration rate, EGFR, or creatinine clearance. For antibiotics, such as vancomycin or gentamicin, renal dosing adjustments are required to avoid nephrotoxicity. Dosing frequency may be reduced in patients with low EGFR. Opioids like morphine require dose reduction in CKD due to accumulation of metabolites, e.g., morphine 6-glucuronide, that can cause CNS depression. Digoxin, a cardiac glycoside, is also cleared renally and requires dose adjustments to avoid toxicity, especially in CKD patients with low EGFR. These adjustments are often based on renal function, EGFR-ERCL, and the pharmacokinetics of the drug, with the goal of ensuring therapeutic efficacy while minimizing the risk of adverse effects. Regular monitoring of drug levels is also recommended when possible. What is the role of corticosteroids in the management of glomerulonephritis, and what potential complications should be monitored during therapy? Answer: corticosteroids are used in the management of glomerulonephritis (GN) to reduce inflammation and modulate the immune response. They work by suppressing the production of pro-inflammatory cytokines and reducing the activity of the immune system, which is often overactive in glomerular diseases. In nephrotic syndrome or other types of GN, corticosteroids like prednisone are often used as first-line therapy to reduce proteinuria and prevent further kidney damage. However, long-term use of corticosteroids carries potential risks, including osteoporosis due to reduced calcium absorption and bone mineralization, hypoglycemia potentially leading to steroid-induced diabetes, hypertension, as corticosteroids can lead to sodium and water retention, increased susceptibility to infections as corticosteroids suppress immune function. Regular monitoring is essential, including bone mineral density scans to monitor for osteoporosis, blood glucose levels to manage steroid-induced hypoglycemia, blood pressure monitoring to prevent hypertension. What factors should be considered when deciding whether to start dialysis in a CKD patient, and how do uremic symptoms guide this decision? Answer: the decision to initiate dialysis in CKD patients is complex and based on a combination of clinical symptoms, laboratory values, and renal function. The key factors to consider include severe uremic symptoms such as persistent nausea, vomiting, loss of appetite, fatigue, or mental status changes indicating that the kidneys are no longer able to remove waste products from the blood effectively, severe fluid overload leading to heart failure or pulmonary edema which cannot be controlled with diuretics, electrolyte disturbances such as hypokalemia which are refractory to treatment and pose a risk to the patient's life, declining EGFR, typically 10 mmol on 0.73, although the decision to start dialysis is more often based on symptoms than EGFR alone. Ultimately, the decision should involve a shared decision-making process with the patient, considering their quality of life and preferences. Early referral to nephrology for assessment and pre-dialysis planning is recommended. Describe the pathophysiological mechanisms that contribute to the development of hypertension in chronic kidney disease, CKD. How does the renin-angiotensin-aldosterone system, RAS, play a pivotal role in this process? Answer: hypertension in CKD is primarily due to a combination of sodium retention, increased vascular resistance, and the activation of RAAS. As kidney function declines, the kidneys lose their ability to filter sodium effectively, leading to fluid retention, increased blood volume, and ultimately hypertension. The RAAS system is a key mediator in this process, so when renal perfusion decreases due to reduced kidney function, the juxtaglomerular cells in the kidneys release renin. Renin catalyzes the conversion of angiotensinogen to angiotensin I, which is then converted to angiotensin II by the enzyme ACE, angiotensin-converting enzyme. Angiotensin II induces vasoconstriction, increasing systemic vascular resistance, and also stimulates aldosterone secretion from the adrenal glands, leading to sodium retention, which further exacerbates hypertension. Relevant guidelines laws. According to the Kidney Disease Improving Global Outcomes KDIGO Guidelines, ACE inhibitors or angiotensin receptor blockers (ARBs) are recommended for managing hypertension in CKD patients to block the RAAS and reduce blood pressure and proteinuria. How do ACE inhibitors and ARBs help in the management of hypertension in CKD, and what are the potential risks associated with these medications in advanced CKD? Answer: ACE inhibitors and ARBs are commonly prescribed for CKD patients with hypertension, as they target the RAAS and help reduce blood pressure, proteinuria, and the risk of progression to end-stage renal disease (ESRD). ACE inhibitors block the conversion of angiotensin I to angiotensin II, while ARBs directly block the action of angiotensin II on its receptors. Both classes of drugs help reduce glomerular hypertension, which can reduce kidney damage. However, in patients with advanced CKD or those with a significantly impaired glomerular filtration rate (GFR), these medications may increase the risk of hyperkalemia, high potassium levels, and acute kidney injury due to their effects on renal blood flow and potassium excretion. Relevant guidelines laws. The KDIGO guidelines emphasize monitoring renal function and potassium levels closely when using ACE inhibitors or ARBs, particularly in stages 3 and 4 CKD. Explain the concept of salt sensitivity in CKD and its relationship with volume overload in hypertensive patients. Answer: salt sensitivity refers to the increased blood pressure response to salt intake, which is particularly prevalent in patients with CKD. As kidney function declines, the kidneys become less efficient at excreting sodium, leading to sodium retention. This sodium retention increases extracellular fluid volume, which results in volume overload and elevated blood pressure. In CKD, this process is exacerbated by a reduced ability of the kidneys to regulate the balance of electrolytes and fluid. Volume overload, in turn, can worsen hypertension, increase the workload on the heart, and promote the progression of CKD. Relevant guidelines laws. The National Kidney Foundation in Kiev recommends a no-sodium diet for patients with CKD to manage hypertension and reduce the risk of further kidney damage. Discuss the mechanisms by which CKD leads to left ventricular hypertrophy (LVH) and how this condition contributes to cardiovascular complications in these patients. Answer: LVH in CKD is often a result of prolonged hypertension, volume overload, and anemia. Elevated blood pressure increases afterload on the left ventricle, causing it to work harder and adapt by increasing muscle mass hypertrophy. Additionally, volume overload from sodium retention increases cardiac output, further stressing the heart. Anemia, a common complication of CKD due to erythropoietin deficiency, leads to a compensatory increase in cardiac output, which can contribute to LVH. LVH is a significant risk factor for heart failure, arrhythmias, and other cardiovascular events, all of which are common in CKD patients. Relevant guidelines laws. The KDIGO guidelines recommend controlling blood pressure and managing anemia to reduce the risk of LVH and subsequent cardiovascular complications in CKD. Mr. Thomas, a 58-year-old male with stage 3 CKD, has been struggling with uncontrolled hypertension despite being on an ACE inhibitor and a diuretic. His recent blood pressure reading is 107/95 mmHg. His serum potassium level is 5.5 meckel. Given his potassium level and hypertension, what adjustments would you make to his treatment plan? Answer: in this scenario, Mr. Thomas is experiencing uncontrolled hypertension and his potassium level is elevated. First, it's crucial to assess his adherence to medications and lifestyle modifications such as sodium restriction and weight loss. Given the elevated potassium level, it's important to evaluate whether the ACE inhibitor is contributing to hyperkalemia. ACE inhibitors can increase potassium levels, especially in CKD patients. The treatment plan should involve reevaluating the use of the ACE inhibitor. Given his elevated potassium levels, ARB may be considered as an alternative, but it should also be monitored closely for hyperkalemia. Adjusting diuretic therapy. A potassium-sparing diuretic should be avoided or substituted with a loop diuretic to help manage volume overload and hypertension while controlling potassium levels. Potassium-lowering strategies. If hyperkalemia persists, medications such as sodium polystyrene sulfonate or dietary potassium restriction may be necessary. Relevant guidelines laws. The KDIGO guidelines emphasize careful management of antihypertensive therapy and monitoring of serum potassium in CKD patients. How can diet and nutrition management help alleviate common uremic symptoms such as anorexia, nausea, and fatigue in CKD patients? Answer: nutritional interventions can help manage uremic symptoms by addressing the underlying metabolic abnormalities that contribute to symptoms like anorexia and nausea. For instance, anorexia can be alleviated by offering small, frequent meals that are easy to digest and high in calories and protein. The use of appetite stimulants or nutritional supplements may also be considered. Nausea is often related to uremic toxins that accumulate in the bloodstream. Dietary modifications, such as reducing the intake of foods high in phosphorus and potassium, can help manage nausea. Additionally, ensuring adequate hydration can prevent electrolyte imbalances that contribute to nausea. Fatigue in CKD is commonly caused by anemia and poor nutritional intake. Managing anemia through erythropoiesis-stimulating agents, ESAs, and ensuring adequate iron levels can help improve energy levels. Relevant guidelines laws. The KDIGO guidelines recommend individualized dietary management for CKD patients to address specific symptoms and improve overall quality of life. What are the common micronutrient deficiencies seen in CKD patients, and what strategies can be employed to address these deficiencies? Answer: common micronutrient deficiencies in CKD include deficiencies in iron, vitamin D, and calcium. These deficiencies occur due to a combination of reduced dietary intake, impaired absorption, and the loss of these nutrients during dialysis. Iron deficiency is common in CKD due to decreased erythropoietin production and blood loss during dialysis. Oral or intravenous iron supplementation is often required. Vitamin D deficiency results from the kidney's reduced ability to convert vitamin D to its active form. Supplementation with vitamin D or its active form calcitriol may be necessary. Calcium deficiency is also common, especially in patients on phosphate binders. Careful monitoring of calcium and phosphate levels is essential to avoid calcification. Relevant guidelines laws. The KDIGO guidelines recommend supplementation and monitoring of these micronutrients to prevent complications such as anemia and bone mineral disorders. Explain the critical role of a dietitian in the management of CKD patients. How does collaboration with healthcare teams improve patient outcomes? Answer: dietitians play a vital role in managing CKD by providing individualized nutrition counseling and creating meal plans that address the specific needs of CKD patients. They work closely with nephrologists and other healthcare providers to assess nutritional status, identify risk factors for malnutrition, and provide appropriate interventions such as adjusting protein intake or managing micronutrient deficiencies. Educate patients. Help patients understand the importance of dietary restrictions such as sodium, potassium, and phosphorus to prevent complications like hypertension, hyperkalemia, and bone disease. Monitor dietary compliance. Track patients' progress in meeting dietary goals and adjust plans as necessary to optimize kidney function and overall health. Relevant guidelines laws. The NKF encourages the involvement of dietitians in the management of CKD to improve patient outcomes, emphasizing the importance of individualized care. How do dietary needs differ across CKD stages 1, 4, and what are the key components of a low-protein diet for CKD patients? Answer: dietary needs vary significantly across the stages of CKD. In stages 1, 2, the primary focus is on controlling blood pressure, managing proteinuria, and preventing further kidney damage. A diet rich in fruits, vegetables, and low in sodium is important. In stage 3, protein restriction becomes more important to slow the progression of kidney disease. A low-protein diet, 0.6-0.8 grams body weight per day, may be recommended to reduce the kidney's workload and delay the need for dialysis. In stage 4, additional restrictions may be needed, such as limiting potassium, phosphorus, and sodium. Supplementation with vitamins and minerals may also be necessary to address deficiencies. Relevant guidelines laws. The KDIGO guidelines support individualized dietary modifications depending on the stage of CKD to optimize patient outcomes and minimize progression to ESRD. Explain the relationship between hyperkalemia and cardiovascular risk in CKD patients. How does hyperkalemia affect the cardiovascular system, and what are the primary strategies for managing it in nephrology practice? Answer: hyperkalemia increases the risk of cardiovascular events in CKD patients due to its effects on myocardial excitability. Elevated potassium levels can lead to changes in the resting membrane potential of cardiomyocytes, which can result in arrhythmias, including ventricular fibrillation and even sudden cardiac arrest in severe cases. Hyperkalemia can exacerbate pre-existing cardiovascular disease and further increase the risk of adverse outcomes. Management strategies for hyperkalemia include reducing potassium intake, restricting dietary potassium, especially in advanced CKD, medication adjustments, discontinuing or substituting potassium-sparing medications, GAC inhibitors, ARBs, spironolactone, use of potassium binders, medications like sodium polystyrene, sulfonate or newer agents, G-padyrima, sodium zirconium cyclosilicate, to bind potassium in the gastrointestinal tract and reduce serum potassium levels. Dialysis. In severe cases, dialysis may be required to rapidly remove excess potassium.